how did you, I guess, first come to realize what some of the real pain points in today's kind of healthcare system were potentially very amenable or well suited for the kind of technologic, advancement that is AI?
Yeah, well, first, I want to be honest with you and the listeners, and that is that, my story starts with AI because I'm a lazy piece of shit.
I don't believe that.
And the reality is, like, I'm always looking for a way to work smarter. I'm always looking for a way to maximize productivity. I'm always looking for a way to boost the output of my employees and my staff, right? So I'm hungry for those resources, those opportunities. I'm hungry for those tools. At the end of the day, AI is just another one of those tools. And so my AI journey started, with large language model. I'm sure you remember the early GPT-3 days and,
Yeah.
asking, Chat GPT to create a poem for you in Swahili and all that. Yeah, you know what I'm talking
Or
about.
haiku.
It was like just pure entertainment. But now I would say, I roughly use it 3 times per second. I'm just kidding.
Right?
I use it fairly regularly. And it is one of the most important things that we look out for in our hiring process at A Healthier Democracy. We'll get into what our organization is in a bit, but it is in the lifeblood now of our organization. We signed a big deal with Northeastern Burns Center for Social Change, where they are basically, it's almost like electrifying the grid of our nonprofit, of A Healthier Democracy, with AI. And so it's a 3-year deal where their AI technologists are really helping us sort of look at every aspect, all of our programs, patient voting, VoteER, Link Health, which we'll talk much more about, and asking the question, how and where can we begin to leverage large language models in each of these different programs?
And, part of the allure is probably that these large language models can really help you get through a plethora of stuff or things, like, be it, patient demographics, be it healthcare metrics, be it outcomes that, leave more to be desired and can be more optimized. It's a mess, especially when it comes to nonprofits, and I say when it comes to nonprofits, because somebody is having to do that. And oftentimes, driven by purpose. Yeah. And now you can expedite what generally for nonprofits, people that are doing things outside or in their free time or like employed, but for just such a good purpose, you can expedite all that really fast. It has truly uncovered the identification process. So what are some of those pain points, like, I guess more specifically when it comes to things relating to, your world outside of ER, which is very much this whole ensuring things that exist, which is policy, which is legislation, which are all those things, especially as they relate to healthcare. What are some of those pain points that you are seeing, like, this is what it's doing? Like, this is a problem we've had for a long time, having done this, I think a decade now, probably longer. I'm not sure because you look very young. But what are those things that immediately to you are like, these are the things that were such a pain that we can do now?
Yeah, well, let me get into the work that we're doing at Link Health and how we're using AI to connect patients to over $80 billion in unspent federal and state aid that patients can use to do things like help them, put food in the fridge, to pay their phone bill, to get rental assistance and avoid eviction. The work of Link Health for me really started, I know you mentioned, sort of separating out the ER work from the work that we do at A Healthier Democracy. But it's all intertwined for me, like this work really started in an emergency room. And the idea being that, when folks think of the ER, right, they think of, gunshot wounds, strokes, heart attack,
Calamity.
right. But the reality, and look, and I'm here for it. I love that. I'm here for it. But the reality is 40 to 50% of the patients that we're seeing in the ER, they don't need to be in the ER. They're there because they have a social emergency. They're there because they have a public policy emergency. Just like the guy I saw 2 nights ago, homeless gentleman, had nowhere else to go, and it was his birthday. So he showed up to the ER, right?
Huh.
And here's the problem with that. That's a $3,000 visit. We did nothing for this man. I give him a turkey sandwich. I did mix up a little mix. I call it, it's my mocktail. Okay. It's my emergency medicine mocktail. A little bit of Gatorade, a little bit of cranberry juice and some ice. So so
Get out of here.
he got served, but that cost us $3,000, right? So the
40
reality
to
is
50% of these the cases in the ER ish you're saying are due to truly a non-medical emergency in the emergency room.
they are due to upstream systemic failures in people being unable, right, to either access what they really need from the healthcare system, or they're there, quite frankly, for an issue that's related to housing or food insecurity, not being able to eat. I had a patient who I still, to this day, think about, this young woman who came in, 20-something, came in with abdominal pain, and couldn't get a good story out of her. So, when you don't, you know how it is, Sanjay, when you can't really get a lead on the story, you kind of broaden the diagnosis. So we're thinking, this is appendicitis, this is a UTI, etc. She's pregnant. We get her labs back. She has starvation ketosis.
Oh,
She had abdominal pain because she was hungry. I asked this young lady, what's up? What's going on? Like, tell me, shoot it straight with me. And she said, well, my dad's been getting more sick and his medication costs are going up and we've had to make decisions. Do we put food in the fridge? Do I get him his Parkinson's med? Right? So the bottom line is, this is real shit, right? So when I went to the White House and I worked in the Biden White House, the Biden administration, one of the big things that I learned is that every single year there's over $80 billion in funding. That's federal funding, that's state funding, that are these financial assistance programs that people do not take advantage of. And they don't take advantage of them for various reasons. We're going to get into that. But the bottom line is this: the patients that we are seeing in ERs, like our Medicaid population, they live on an average of $21,000 per year. $21,000 per year. That's their annual income. And so these folks are having to make decisions all the time about whether or not their healthcare is more important than some of their other needs. And so Link Health is all about connecting those patients to those financial assistance programs, and we use AI to do it.
that's phenomenal. Am I mistaken, though, to say is the thinking behind it not to help with their emergency medicine costs, but to actually help support and do the things to keep them out of the emergency room, to where those dollars actually result into a significant potential cost savings, because you just quoted 40 to 50% that are non-emergent situations, but you got to pay the staff, the triage, the time spent, the opportunity cost, the IV, all of this stuff that's being hemorrhaged for issues that there is already money sitting on the shelf to be able to hopefully salvage.
Precisely.
So it's not just a negative, like when it comes to the overall, system in America, it's not this like huge, negative of 80 B, but it's like that, which we'll never be able to, or maybe we can with AI, actually be able to show and substantiate what is actually saved by having a reduction in 40 to 50% of ER.
Let me build on that, because our colleagues at Deloitte just published this incredible report which nailed it. They published a report on the health wealth gap. The health wealth gap is this idea that folks who are living in poverty, guess what? Not only do they have a much, much, much higher likelihood of getting chronic diseases, of developing cancer in your world, but they also put a tremendous financial strain on the healthcare system. The patient is in the ER with abdominal pain because she is hungry. Yes, we gave her food. Yes, we made sure she did not leave without, a list of resources. But did that need to be an ER visit? And look, I'm here for it. We're always going to be open. But I think that there is a better way. I'll tell you one other thing. There's a movement now in medicine that is being termed the money as medicine movement. Money as medicine. Why? Sanjay, you have had the same exact experience I have. You have a patient in front of you. They have a need. And the thing that you and I can do is write them a prescription, when in reality, what we both would want to do is write them a check. So guess what? America has already written them a check. It's called these public assistance benefits, but they're not accessing them. And AI can be the bridge to do that and make sure these people actually get what they need. And the studies, to your point, Sanjay, you've immediately intuited it. The studies demonstrate this. Deloitte impact report demonstrates about $320 billion a year is the cost of this. The direct costs of folks living in poverty, being sick, and then having to be taken care of in these other ways.